we know that ovarian cancer is an angiogenic tumor. And in recent years, important small molecule inhibitors, biologic agents, have been developed that target components of angiogenesis. Bevacizumab is an example of that. The discovery of this drug and the development in ovarian cancer has led to two large upfront randomized phase 3 trials, GOG 218 and ICON 7. Both of these trials showed a positive result in that there was a statistically significant prolongation of progression-free survival in both studies. For GOG 218, it was approximately 4 months. For ICON 7, it was about 2.5 months. Of interest, neither trial demonstrated a prolongation of overall survival for the patients enrolled on the bevacizumab concurrent and maintenance arm. This has raised the question is who should actually get treated with bevacizumab? And it's a relevant question because it is a relatively expensive drug and has some manageable but nevertheless important toxicities. So there's been a large effort to identify both clinical, blood-based, and tissue-based biomarkers to predict who would benefit or not benefit from the treatment with bevacizumab. Clinical data would suggest that those patients with high-risk tumors, meaning suboptimally debulked, may benefit. However, this is highly dependent upon the surgeon and may not accurately reflect the biology of the tumor. A second approach has been to look at serum or plasma-based biomarkers. A panel of biomarkers tested in pre-chemotherapy sampling in GOG 218 has shown that none of them have a statistically significant predictive value for the effect of bevacizumab. A third approach has been to look at tissue-based markers, and the group from Scotland with Charlotte Gordley has looked at gene signatures, which suggest that gene signatures may predict for patients who both benefit and potentially are harmed by bevacizumab. The validation of this is pending. Another approach taken by ourselves is to look at CD31 expression, which reflects microvessel density. And this data demonstrated that all of the progression-free survival advantage and even overall survival advantage was predicted by higher than median expression of CD31 or microvessel density. This study also needs validation, but I think provides early data that we can identify patients who will benefit and patients who will not. And this has an impact on the care of our ladies because it is an expensive drug and has toxicities, and we can maximize therapeutic intervention.